Get started. To oh, I want to introduce me as the Senior Vice President of Clinical Operations at Promises Behavioral Health. We are an organization that treats both those with substance use disorder as well as mental health. This is why this is so critically important. I say this at every training. As somebody that is a trauma expert, I always encourage individuals when you are trying to access care for somebody that is needing it. One of the foundations of trauma is to help within those transitions. So I strongly encourage you to pull up our website if you're going to refer to us, walk through the pictures and the sites for those that you might be referring so that they have an understanding as to where it is. I always equate it to if you have a child that you've ever gone on a college visit, you liked seeing where this child was going to lay their head at night. You wanted to see what their surroundings look like because you knew that it was going to provide ease for both you and your child. And that is no different for an individual that is actively seeking their own recovery. So we have 7 inpatient locations, 1 in the state of Massachusetts, 1 in the state of Pennsylvania, which is where I am from, 1 in the state of Florida, 3 in the state of Texas, and 1 in the state of Tennessee. We also are continuing to expand our continuum of care for our inpatients so that we can service those in a PHP and an IOP level of care. And we currently have 2 outpatient locations, 1 in Georgia and 1 in North Carolina. So we are continuing to find ways that we can service those that need help and access as they look and explore their recovery journey. I'm going to introduce you to Callie. She is my partner on all of our Promises Behavioral Health webinars. So I'm going to flip this over to her so she can talk a little bit about your continuing education credits, which I know is critically important.
Yeah, thanks, Trish. Welcome back to everyone that's been here before, and welcome to everyone that's new. We do these every month. So it's the 4th Friday of every month, and we always offer free CEs. So just to reiterate, if you've heard this already, you have to be here for 90% of this meeting. So if you miss more than like 5 to 10 minutes, we really can't accept that. And that's not my role. That's an accreditation role. You will get an email that says if you met the time criteria or not. Most of you that are here right now will. And then just make sure, like I said earlier, that if you're signed in through Zoom, the email that you're signed in with is the one that you'll need to fill out the evaluation form. You'll get an evaluation form from me, and it'll come through JotForm. If you want to go ahead and go into like your email account now and like add in, to check for JotForm later, that's like the email that's going to be coming in through, and that will be an automatic email that will come in. Give me like 2 hours to sift through all the data, and then you'll get that later today. When you get the evaluation, you'll fill that out and it actually will automatically send you your certificate after. So you don't have to wait on me to send that back to you. Make sure that you just look for that. Again, it'll come from JotForm. So, and just to also reiterate, you have to fill out the evaluation within a week of today's learning. So if you're thinking right now, like, man, I didn't get the evaluation or didn't fill out the evaluation from last month, I won't be able to help you with that. It has to be done within a week. So I'll send out a reminder email on like Monday, just to make sure that if you didn't fill it out today, then you could do that as soon as possible. But yeah, just make sure you get that to me by next Thursday. And I will close the evaluation, so you won't be able to fill it out after next Friday. Oh, and then the slides, other resources, today's webinar is being recorded. If you need anything, additional information, you will get that on Monday or Tuesday of next week. Trish and I will compile the highest level of resources and books that she mentions or anything like that. All of that will be sent to you next week. And I think that's everything. Oh, last bit, if you are here, and you have a question specifically for Trish about the training, put that in the Q&A. That will help me stay organized. So a lot of you will send me information in the chat, like to check on your email and that kind of thing. I'm happy to help you do that. Just keep that in the chat and then keep the Q&A separate. I want just questions for Trish in the Q&A so that we can make sure we get those over to her. I think that's it.
All right, thank you so much, Kelly. So these are our upcoming trainings. So next month, we will have a path forward for mental health and substance use disorders. This is going to be facilitated by our executive director, Sarah Goldman at our Right Set in Houston. And then in June, we have Lauren, who is the Director of Clinical Operations for our Ranch in Tennessee facility, who will be talking about holistic trauma treatment. So please, you can register now, or you can continue to kind of check us out to see what we're going to continue to offer. This is our part of our commitment to being a part of the community solution and providing free continuing education to professionals. All right, so let's get started. So the objectives for anybody that has ever done a training with me, you will hear this. Objectives are everything that I'm going to go over, so I don't need to spend any time going over it with you right now. Boop. All right, so let me start with this idea of breaking the silence. I started the topic with that sentence because I have been in the behavioral health space for about 27 years. I have actively worked with those that have experienced both suicidal ideation as well as suicide attempts. And what I have found that continues to stump me, for a lack of a better word, is the silence and the secrecy that still surrounds suicidal ideation and thoughts. And so today, what my goal is to start to break that silence. We know it within the world of substance use that the disease sits in the secrets. And so the field of substance use has actively worked towards reducing stigma of kind of shouting out loud somebody that has been struggling with substance use to no longer carry the burden of the shame and the stigma associated with it, right? We want people to be able to say it. We want people to know they're being heard. We want people to feel connected. But when it comes to suicidal ideation and attempts, we still struggle. And so today, the goal, again, is to start to break the silence. So how do we start with that? I want us to think about how do we feel and communicate about suicidality? We are talking about a very sensitive topic, so I want everybody here to put their safety plans in place, right? Their own personal safety plans as we navigate through this. But this is an opportunity for us to have a conversation about something that is both very delicate and very critically important for us to have a conversation about. If I were to ask you, if somebody came to you and said, I'm really struggling with thoughts of wanting to use, I'm really struggling with having urges of wanting to access alcohol or substances, and I were to ask you, how do you feel about that? Like in this moment, when I say those words, do you feel anything in your body? When I ask this question, most people say no, and I'll go, okay, so what do you do about it? And we as professionals say, no matter what your role is, right? So we're all in this. Trauma Informed says that everybody, the most important person is the person standing in front of somebody when they have a moment of need or crisis. But when I say it within substance use, people are like, I talk to them about the reasons why, they chose sobriety. I talk to them about the importance of their family, of staying connected, right? That we've been there before, right? All of these things that allow for us to say it's normal to have an urge. It's normal to have a thought of wanting to use again. And it doesn't mean that you will, and it doesn't mean that you're not still invested in your recovery. When I say the words, I want to kill myself, I want to die, physically in your body, as I say those words, does it feel different? Because when I ask a live audience, the overwhelming majority of them say, oh, I feel it. I feel it in my stomach. I feel the tension in my back. Because we, as professionals, struggle with that sentence. But if we, as the professionals, struggle with that sentence, then how is somebody supposed to be able to say those words out loud? I'm going to go through a lot of statistics about suicide, but I'm going to say something that most of us don't want to hear. And the reality is that we have close to 600 of you on this call today. And I'm going to say probably 90% of you or more has had a thought of, I wish I wasn't here anymore. 90% of you have probably thought at one point or another, oh, God, I don't know if I want to do this. It's so common. There's no fear to having those thoughts. There's no fear to having the experience. There's no fear in the ideation. Breaking the silence is creating a space for us to be okay with somebody saying those words in the same way that we can hear, we can validate, and we can stand next to somebody that says, I'm struggling with wanting to use a substance. I still have thoughts of it. I have dreams where I want to use again. We need to get to a place as behavioral health that we feel just as comfortable when somebody says, I want to die. I want to kill myself. We need to create that silence and open up opportunities for people to say those words out loud, to not feel shame, to not feel afraid that they're going to be sent somewhere else, that they are okay to be able to have those words, and that we're going to start navigating them through their own recovery in the same way we would for any other behavior. So that becomes the starting point. When we look at the idea of what we're talking about today, which is a trauma-informed approach, everything I do is trauma-informed. I'll say that one more time. Everything I do is trauma-informed because it's basically at the root of who we are and how we present to those that are asking for care. So look at Sam's trauma-informed approach. It identifies these three core pieces of what trauma-informed is. And it means that the entire organization, so I know here at Promises, when I came in here, I very directly moved into creating us as a trauma-informed organization, meaning everybody in the organization needs to participate in a training. Housekeeping, dietary, therapists, behavioral health specialists, CEOs, clinical directors, everybody needed to hear the language of what trauma-informed is. Because what we understand with trauma-informed is that, again, as I had said earlier, the most important person to a patient that is experiencing a crisis is the person standing in front of them. They don't care what your title is. So it can be a housekeeper that is equally as important to the person in a crisis as it is a behavioral health technician, as it is a therapist. People just need to feel heard and connected, and that they are in a safe space to be able to be themselves. So everybody is equally as important. So that means everybody needs to participate in that training to learn how to realize the widespread impact of trauma and understand its path to recovery. How to recognize the signs of trauma in our patients, in their families, in our community, in our staff, in everyone. We need to help inform people what trauma looks like. Having been doing trauma for way more years than I care to admit, the reality is that I can't tell you how many times people say, oh, I would love to work in trauma, until they see the first person who's experienced trauma, because it doesn't look like how you want it to look. It looks angry. It looks afraid. It looks aggressive. It looks disconnected. It looks the way that its symptom is going to show. So you need to train everybody on how to recognize those signs. And then we need to teach our teams on how to respond to it. Because the difference between responding to trauma and reacting to trauma is that if you understand what trauma is, which is basically a fight or flight, right? Sometimes freeze. When you react to a survival skill, you get bigger, right? Somebody's coming after you, you get bigger to try and fight that off. If we as the professionals start to react to our patients' experiences because we are judging them, because we are unconsciously saying that you need to be better, act better, and behave better, then we are not responding to their trauma. We are reacting to their behaviors. Trauma-informed says we need to respond. And our response is going to allow for somebody to be able to either get safe or get worse. So when we look at systems and organizations that implement a trauma-informed approach, It creates a safer environment for their staff as well as their patients. So this is why that becomes so critically important. And then just as a subtle difference, right? So trauma-informed approach is different from a trauma-focused care, right? Which centers on the impact of specific trauma on an individual's life. That's the individual sessions versus trauma-specific services, which are clinical interventions designed to address the trauma-related symptoms. So you're seeing the layers. Trauma-informed approach is the organization learning how to realize, recognize, and respond to individuals who have been impacted by trauma. These are the 6 guiding principles to a trauma-informed approach. There will be resources towards the tail end, right? So these are also from SAMHSA. I highly encourage you to review those if you have not already. But again, those principles of what it means to be trauma-informed, creating safety, creating trustworthiness and transparency, creating peer support. You're going to hear a lot about this. Peer support, collaboration, mutuality, empowerment and choice. Keep in mind as we go through this, trauma-informed approach, trustworthiness and transparency, peer support, collaboration, empowerment and choice, and cultural, historical, and gender issues. These are all critically important to a trauma-informed approach. And we're going to go through this to see how they all interlink to trauma, substance use, suicidality. So I'm going to do a very quick kind of overview on brain development because it becomes critically important. So again, for those of you that have ever participated in any training that I've done before, right, I am a brain-based person. Why am I a brain-based person? Because trauma has been historically, as is a lot of behavioral health, been viewed as anecdotal at best, where we talk about treatments in the way that we talk about feelings. That we say we're condoning behaviors or we are justifying behaviors because we are choosing to engage in a trauma-informed approach with a patient where we are responding to them rather than trying to dictate or discipline. And so in the same way that if you had diabetes, what you wouldn't do is talk about the feelings of diabetes in a way that was saying, this is how you're going to get better. Certainly somebody needs to be able to talk about their feelings about how they're struggling with, I don't like that I have diabetes. It's incredibly stressful. You know, I have sadness with it. I have anxiety with it, right? All of those things. But nobody tries to talk about somebody's feelings when they're trying to cure or manage diabetes. We do that in behavioral health. Somebody's got trauma, somebody's got substance use, somebody has an acute mental illness, and we are trying to process their feelings to help them manage these experiences as opposed to actually treating them. So when we look at the brain, and again, I'm going to do a very quick overview. I've certainly gone into greater depth when we did the trauma-informed training. But the brain develops, all of our brains develop in the same way, from the bottom to the top, from the back to the front. And so you're seeing this projection of how the brain actually develops. Those sites being a lot more mature, it's more of a limbic system, and the brainstem and the amygdala. So when we look at how a brain is developed, at the bottom, very bottom of the brain, that brainstem, all senses come into it. Based on your history, based on your personality, based on your experiences, that information from all 5 of your senses that comes through the brainstem makes very quick decisions as to if this information is novel, no big deal, or if this is triggering to an event from your past. As that information is funneled, it makes a decision. Do we need to shoot this directly to the amygdala, which is the fear response system of the brain? Do we need to say, this is no big deal, right? So we're going to move it through. You can get to the cortex. So somebody cuts you off in traffic, right? Senses are coming through. You get mildly annoyed, right? So your amygdala gets tapped in. You get to the cortex pretty quickly because you weren't really actively triggered. You get to the cortex and you're like, I'm not going to do anything. I'm not going to do road rage. I'm not going to give them the finger. I'm not going to do any of these things, right? Because your cortex is like, it's not worth it. That's very different for somebody that maybe have had an accident, because their system is gathering this information from the bottom of their brain. And their brain is like, the last time this happened, you got into a car accident. This is life or death. And so it goes directly to the amygdala. It floods your body. The adrenal system kicks in, right? And that's where you see this heightened elevation of a reaction that the cortex, the rational part that says, you know, it's probably not a great idea to like tailgate. It's not a great idea to give somebody the finger. It's not a great idea to become aggressive in driving. That part of the brain doesn't get activated. So when we talk about substance use and trauma and suicidality, we're going to be spending a lot of time in that limbic system and below. The cortex for somebody that's been actively triggered, which is the rational part of your brain, which is the problem-solving part of your brain, which is the part of your brain that wants sustained recovery, wants to do well, wants to be able to have the coping skills in order to navigate their suicidal thoughts. That part of the brain gets shut down the bigger the trigger. And so as we go through this, I'm going to start tying in how all three of these things, trauma, suicidality, and substance use, relate. But I want you to keep in mind, when we say the brain states, the cortex, the rational part of the brain, the bigger the trigger, the less it's being used. The limbic system, which is responsible for your fight or flight, it's responsible for the nucleus accumbens, which rewards the behaviors. So I'm going to circle back to that, rewards the behaviors that worked, right? Tells you to do that again. So I'm going to touch on that when we talk about self-harm. Those are the parts where we're seeing individuals that are in that limbic system, right? It's also the part of the brain that responds when you use a substance, right? The pleasure reward center. So quick facts on suicide. In 2021, more than 48,000 people died in suicide. That's one death for every 11 minutes. 12.3 million adults thought about suicide. If I'm being honest, I'm going to argue that's not true. That I think most people at some point in their life thinks about suicide. Doesn't mean they had the intent, doesn't mean they had the plan, but I'm going to argue most people at some point thought it. 3.5 million adults made a plan and 1.7 million attempted. When we look at the rates in males in 2021, and again, I'm only going to highlight some of these because of we are behavioral health specialists. When we start to navigate how do we assess appropriately, it becomes important for us to recognize some of those higher risk areas. And so when we're looking at 2021, men were 4 times higher than women. And males make up about 50% of our population, but nearly 80% of our suicides. And I think most of us are aware, right? So men choose a stronger lethality. So that is why they're making up 80% of the suicides, because if they act on it, they tend to act in a way that is more lethal. So guns and hangings. Now, words matter. So this is going to be another pain point for me, right? So this is, I'm going to stand on a soapbox for just a couple of minutes and then I will step back down. But words matter because, again, having been in the behavioral health space for a very long time, I would hear things like, you know, well, she or he engaged in self-harm, so they are a suicide risk. There is a clear distinction that self-harm does not equate suicide or suicidal ideation. It can, just like using alcohol can be an attempt to, or using a substance can be a direct attempt to overdose. It also might be the symptom of their disease. So non-suicidal self-injurious behaviors for all of us in the professional world does not guarantee suicidality. It's a behavior that we have to look at, that we have to treat, as we would any other behavior associated with any other mental health diagnoses. So this chart does a nice job of identifying self-injurious behaviors. Is it a suicidal self-injurious behavior? We got to ask. We have to ask those questions, right? So then it drops down and you can see that might be a suicide attempt. If it's undetermined self-injurious behaviors, then we need to ask, is the intent for suicide or was the intent for a reprieve? Were you looking to feel differently? Because when I go back to that brain and I had said, keep in mind that limbic system where the pleasure reward center is, when somebody engages in self-harm, it releases endorphins. The brain decides what did and didn't work. So for somebody that felt disconnected from the world, from somebody that felt overwhelmed by their depression, for somebody that has felt that they can't feel anything, they're becoming numb, self-injury can bring them back to feeling something. It's not an attempt to die. It's actually an attempt to live. So we have to make sure that we are not assuming that the second somebody engages in support, that they just tried to kill themselves. That would be considered the non-suicidal self-injurious behaviors. So words matter. So when we look at the difference between suicidal ideation versus attempt versus plan, suicidal ideation, thoughts about self-harm, thinking about wanting to die. We want to pay attention to it, but it is the precursor to asking additional questions about the attempt. Self-inflicted potential injurious behavior with a non-fatal outcome, right? So this was an attempt to end their lives. And then the plan, the proposed method of carrying out a design that will lead to a potentially self-injurious outcome. And again, I'm aware that this is a triggering topic, but it's incredibly important for us. Once upon a time in my career, we had a patient that was expressing suicidal ideation, who had a history of attempts, right, within the last 5 years. But in the moment that they were expressing it and they were in a controlled environment of treatment, this was a patient that was about to get sent to a higher level of care. And so when we had a conversation, or I will say when I had the conversation of what was going on, this was a patient that when asked, what's your plan? Because we said, do you have a plan? And they said, yes. And we were like, okay, right? They need to be sent to a higher level of care. When I asked, what's your plan? The patient said, keep in mind, this was a patient in treatment, a controlled environment. The patient said, my plan is to either use a gun or jump in front of a train. So they don't have access to a gun in our treatment facility. And we don't have any train stations near us. So this is a patient that is appropriately expressing where their concerns are, where their plan is, but not fully understanding what that means, because to just send them to a higher level of care without due diligence of what exactly is this, then we sometimes can become a part of the cycle. This was a patient that we were able to keep in treatment because she expressed herself, because she expressed what she was thinking. She was saying that she was having these thoughts. We were able to engage in some protective factors, which we're going to talk about today, because the plan that she had wasn't feasible. She was honest. She told us her plan, and we knew that the plan wasn't going to happen because she didn't have access or means to either. So that becomes a critically important piece as well. There are a couple of questions that I will answer quickly. If this isn't covered during the presentation, I'm interested to hear language used in talking with family of the suicidal person that dismiss SI, saying that it is for attention. I will probably circle around there. Yeah, you'll probably hear that when I get to the protective factors. When it comes to stats about suicide completion, attempts, etc., do you have stats that break down by class, orientation, race? Yes, they do. So if you go to the CDC website, they have the most current. I didn't put it in here because it would weigh down the presentation. I could do an entire presentation on just statistics and facts on suicidality. But if you go to the CDC, they do break it down by class, orientation, race, gender, age, right? So they are able to break that down as to what that looks like, and you'd be able to identify. Statistic of 2021 was during the lockdown and pandemic. Doesn't that confound the validity of the statistics? So we can look at the statistics pre-pandemic, we can look at them Post-pandemic, certainly what we know for certain is that the pandemic has increased the suicidality. We also know that the pandemic increased some of the mental health acuity. We also know that the pandemic increased the ability to connect, right? So creating kind of a storm of what we saw within a crisis. I'm going to challenge a little bit of the thoughts of, does that confound the validity of the statistics? The statistics are the statistics. The root cause as to why we are seeing our nation increase in some of the suicidality, why we are seeing it, that's just the cause. The statistics are the statistics. So whether it was the pandemic, whether it's the historical trauma, whether it is substance use, whether it is, these are the reasons why we see it. The facts are what we are dealing with. And so, yes, I think, again, we're seeing that this was a dramatic change. We are also seeing that trends are still continuing post-pandemic. When it comes to those with trauma-based reactions, do you have any guidance for providers when there's transference from the client? When a client's trauma-based behaviors trigger personal trauma? Yes, so that would be a great training. You know, I have a wonderful coworkers that do a lot of person of the therapist training. The transference from us is exactly what we're trying to talk about, right? So this is an opportunity. If you are a provider today saying, you know what, this does trigger me. This is why I say this so point blank of like, I want to die. Because I want you to pay attention. If you are having a physical reaction to those sentences, I encourage you to seek supervision. I encourage you to seek your own therapy, because we are humans treating humans, and we are also going to have our own experiences, but our experiences might shut down the possibility of somebody being able to break their silence. If we are not okay with them saying it, our patients are incredibly adept at being able to perceive our reactions, and they will stop saying those words out loud based on our reactions. So yes, that is a wonderful question. Trauma and suicide risks. So again, we're going to look at that link together. So does trauma and suicidality have any correlation? Yes, PTSD is a risk factor for suicide. Risk is primarily decreased by suicide attempts that predated the PTSD diagnosis. PTSD accounts for 6% of suicides in men and 3 to 5% in women. Up to 54% of suicides in people with PTSD are attributable. Now, again, I'm going to determine the difference between trauma and PTSD, because not everybody comes in with a PTSD diagnosis. So we want to track the symptoms. So when I've gone into our own facilities and trained our own teams, I encourage them to track the symptoms, not the diagnoses, because our patients are going to present differently. And if you don't have the diagnoses, but you have all the behaviors, then it's worth treating the behaviors, not the diagnosis. And so we'll go over some additional statistics in a second about kind of the prevalence of what we see in regards to trauma. So I don't stick to just the PTSD diagnosis. I think that marginalizes a very large population that is still struggling with thoughts. I am somebody, again, that strongly encourages these conversations. So when people say that they are starting to see their patients start to be, you know, reporting more suicidality, you can hear the sites getting more anxious, like our patients are saying these things. And I'm like, kudos to your site. Because the reality is that if you work in an inpatient, I don't care if it's substance use or mental health, and you have patients that are denying all, they're not being honest. Because most people do have suicidal thoughts, particularly if you're in an inpatient, right? Whether it is fleeting, whether it's just an ideation, whether it was current or in the past, they're so common that as you see your team starting to hear it more and more, that means your team is creating an environment that says you're allowed to say you're having thoughts of suicide in the same way that you're allowed to say you're having thoughts of wanting to use a substance. That's the direction that we're going. This is how we break the silence. So when we look at substance use and suicide risks, suicide is the leading cause of death among persons who use substances. Alcohol being a significant risk factor. So if they have alcohol, it's 10 times the rate. Persons who inject are at 14 times more risk. So again, this comes in, and I think it's in one of the other slides, right? That the overwhelming majority of those with suicide or with substance use do not commit suicide. So this is not to say that, but it is to say that there are certain risk factors that we need to pay attention to, and suicidality and substance use do have a correlation. So I purposely put this slide on here of shared symptoms. So typically when I do a training on just trauma informed, I highlight the shared symptoms between substance use and trauma, which completely overlap. I added the symptoms of suicidality. And so when you look at this slide, and again, purposely put like, okay, so here are some of the symptoms of somebody that's been impacted by trauma. Here are some of the symptoms that's somebody that has a substance use disorder. And here are the symptoms of somebody that has suicidal thoughts. It's all the same. So I treat the behaviors: being easily startled, being anxious, agitated, changing in eat or sleep. If I were to leave this up to you, you right now probably couldn't look at this list, because I have some that are asterisk, some that are red, some that have nothing. Which is which? Which one is the symptom for substance use? Which one is the symptom for trauma? And which one is the symptom for suicidality? They all overlap. That's the important piece for us to know. They all overlap. So treat the symptom, not the diagnoses. And we're going to talk about ways that we can do that, both from an assessment standpoint, but also from a treatment perspective. But the symptoms are the same. Here's the importance of looking at substance use for a second. So I'm going to highlight a few slides that are specific to substance use, because it's a critically important piece for us to understand this. I've worked with individuals with suicidal ideation who have a history of suicide attempts. And the second that they start telling me that they are drinking alcohol, it's a game changer for me. We have very different conversations once alcohol starts to enter into the picture, because I know the risks dramatically increase when alcohol enters into a picture. So it doesn't mean that they can't share it. It means that I'm having a very honest conversation. For some reason, we kind of know why, right? People are afraid of this. We tiptoe around suicidal thoughts. We tiptoe around saying the right thing or how to say it. But trauma-informed, think back of the 6 principles: transparency and trustworthiness. I'm going to tell you if there's something that's going on that I'm concerned about. You have suicidal thoughts, your depression is getting worse, and you start drinking alcohol. I'm worried you might attempt to kill yourself. That's a fact. I'm saying those words out loud so that we can continue to have an honest conversation and stay connected through the navigation of these behaviors. Those are facts. So when we look at like a general population, and again, the idea of the integration behind all 3 of these, approximately 75% of individuals with a substance use disorder, so this is a general population, have experienced trauma at some point. When we pull that into those that are seeking treatment for substance use, we're looking at roughly 95% of them reporting exposure to trauma. So that means if you are in a treatment facility, you should expect roughly 95% of your patients have experienced trauma. Now, keep in mind the data I just gave you, which is trauma increases the likelihood of thoughts of suicidality, right? All of these things are together. Within a population of individuals with substance use disorder, the experience, when we think of like the ACE studies, the adverse childhood experiences, if you've never seen that, I highly recommend it. The experience of their first trauma is oftentimes in childhood. So then when we look at how the brain develops as a result of the adverse childhood experiences study, we know that if you've had trauma, the younger you are exposed to trauma, the more your brain responds to it and is adjusted to it, right? It leaves footprints on your brain, particularly when it comes to some key parts of the brain, which is that amygdala, right? The fear response system, the nucleus accumbens, which is the pleasure reward center, and the cortex, which is the part that's supposed to be rational, problem solve, and creative. The younger you are with trauma, the more your brain leans on that limbic system, which is emotionally driven, and less on the cortex. When we look at the prevalence of PTSD, also elevated among individuals with substance use disorder, and the co-occurrence between those roughly 25 to 42%. Why this is an important slide is that at the top, I just told you that most of the individuals that are seeking treatment for substance use have a history of exposure to trauma of up to 95%, but only 25 to 42 are being diagnosed with PTSD. Track the symptoms, not the diagnosis. So, substance use, why is this such an important piece for us to pay attention to? No matter if you are in the outpatient or if you are in an inpatient or if you are in a private practice, because it increases the vulnerability. Sorry about that. Alcohol and substance use disorders have been found to strongly relate to survivors, and there are countless studies that show that drug and alcohol treatment shows that past suicide attempts and current suicidal thoughts are common. Let me say that one more time. Past suicide attempts and current suicidal thoughts, common. It's okay. This is what we're here for. So there's things that we need to do to ensure somebody's safety, to empower them, to be able to understand and trust themselves. Because sometimes behavioral health can be a part of the cycle, because every time a patient gets honest, we get scared and we throw them up to a higher level of care. And sometimes that's warranted. And sometimes it isn't. Sometimes it means that we just have to start providing them different skills and different tools to be able to navigate those thoughts. Phrase I like to say is that you can have a thought and it doesn't mean it's an action. That's a fact. You can have a thought of wanting to die or kill yourself, and it doesn't mean that it's that it has to have an action related to it. That's what recovery is. You're going to have all kinds of thoughts. We don't get to control the thoughts, but you got to be aware of them, right? So in our facility, we've created a curriculum that is like recognize, regulate, and respond, because I need individuals to recognize when they're having those thoughts. Regulated, so they choose to respond. If you don't do those things, then you react instead of respond. And the reaction is that I engage in the behaviors that I'm actually actively seeking help with to change. That's how we become partners with an individual that's struggling. So the comorbidity, alcohol and opiate use, highest risks for our patients. So if patients are coming into treatment and they have alcohol use, which is the highest risk, alcohol use is the highest risk because it is a depressant. So you're looking at 2 central nervous system depressants that when you're depressed, increase the likelihood, right? And so those are 2 factors to pay attention to. In treatment spaces, a lot of times we have seen, and I don't have the statistics on that, right? So that would be an interesting one to have statistics. I've not even seen statistics on it. But from anecdotal information, just having been in this field for 27 years, most of the patients that attempt are not the ones that scored high. They had all these other risk factors, but they aren't always the ones that score high. If you look at a first responder, if you've ever treated first responders, they don't even admit to suicidal thoughts. But they're one of the ones that are more lethal, right? We have a high risk for suicide amongst our first responders because they won't say the words. So when you see alcohol and opiate use, these are risk factors because they lower your inhibitions. And so that increases the likelihood of the action. Risk-taking and impulsive behaviors. Yeah, a suicide attempt can be impulsive. It can be planned. That doesn't mean to say that that's not planned, but it is oftentimes impulsive because it's sitting in that limbic system, which is reactive, impulsive, right? Seeking immediate gratification. The cortex, that's the part of the brain that says things are going to work out. You're going to be able to manage this. It's going to be okay. That part of the brain, the higher the trigger, the less that part of the brain is working. Keep in mind, it's the last part of the brain to develop, and it is the one that immediately gets shut down when somebody is actively triggered. They can't even access it. So this is why I focus so much on the regulation, because they need to regulate that first. Otherwise, they can't even get to it. I have worked with a lot of individuals who have had suicidality, none of which wanted it. But in the moment of desperation, in the moment of their pain, if they don't have other solutions, if they don't feel like that they can trust themselves, if they don't feel like they can trust somebody to the darkest secrets of what their brain is saying to them, they risk the impulsive act of saying, I don't want to do this. That is why breaking the silence is that important. Now, when there is chronic opiate use or any substances, but opiates are changing the way that the brain kind of organizes itself long-term, we're seeing neurobiological changes, right? So, and that again is that part of the brain that I was saying. So if somebody continues to use substances, then what happens is that limbic system part of their brain, that nucleus accumbens, the amygdala, those become what would be a louder, right? So it's now that part of the brain that's like using a megaphone to get heard, and the cortex is now in the back seat. It's not even in the front seat of the car. What happens with those neurological changes is that the part of the brain that is driving the car of your behaviors is the limbic system, reactive, impulsive, agitated, seeking immediate gratification. And the part of the brain that's supposed to help you to navigate that, because we all have thoughts, but the cortex comes in and says, it's not worth it. These are some of the reasons why. It's not worth it to pick up the alcohol. It's not worth it to do these behaviors. That part of the brain, that's not even, not only is it not in the driver's seat, it's not even in the front seat anymore. It's in the back seat. Nobody's listening to it. That's what happens. And so the brain is adaptable and plastic. And so the more that you engage in what we're going to talk about with protective factors, the stronger the likelihood of our patients getting well and navigating this. And I will say to this training, as much as I say to people that I'm working with, recovery isn't about getting rid of the thoughts. So if you're telling somebody, you got to get rid of those thoughts in order to get well, recovery isn't about getting rid of the thoughts. Recovery is getting them to be able to recognize that they're having them and regulate them so they don't act on them. I've had people that have asked me, how much longer am I going to have the thought of wanting to die? When am I not going to think of that as a coping skill? I'm like, I don't know. I have no idea. I mean, it could be 6 months, it could be 6 years. That's not where recovery is. Recovery isn't that you don't have the thoughts. Recovery is that you recognize that you just had them. Regulate yourself so that your response can be different. No different than with substance use. I mean, there's people that have been 20 years sober that still have thoughts of wanting to use. They're in recovery. They just recognize that they're having thoughts of wanting to use, and then they regulate themselves by engaging in some of these protective skills so that they don't act on it. That's not what recovery is. We're not going to magically get you to stop changing the way that your brain thinks. It's a complex organ. So helping somebody to recognize that becomes critical. And so when we look at all substances that elevate risk for suicidality, alcohol being number 1, opiates being number 2, then we look at marijuana, number 10 or 10%. That seems like a small number, but keep in mind that marijuana use is increasing over and over year after year. And I'm not going to get on a soapbox in regards to that, right? The difference between legalizing and decriminalizing, right? But the reality is this, marijuana is 10% that it increases suicidality. So you better be having conversations for your depressed patients that are smoking weed, because this is a risk factor for them. 4 and 3 for cocaine and amphetamines. Most of our patients that are using cocaine also use alcohol. So their risks increase because they get this super, super high with the cocaine or the amphetamines. And then because they're trying to quiet themselves down, because they're revved up, they drink alcohol and it plummets them down to a pretty profound depression. So that actually increases it. So those are honest conversations. If you're having patients, I have a lot of times where I've heard people saying that their therapists have said it's good that they're smoking weed because it helps them to manage their anxiety. And I'm like, is somebody having a conversation? I'm not judging one way or another. I'm not here to judge. But is somebody having a conversation? Because if that was a person that was experiencing suicidality and suicide attempts, somebody better be having a conversation that they might be adding weights to their recovery because you smoking weed just increased your likelihood of suicidality 10%. So those conversations, I'm not telling you what to do, but I sure am telling you how to understand you so that they don't feel like I'm never going to get better. Well, you're smoking weed, right? You're still drinking. So your suicidal thoughts are probably going to stick around a little longer because you're actually doing things that are going to make it harder for you to recover. That's all. No shame in this game. That's what I like to say. So again, alcohol and suicidal ideation and attempts, co-occurring alcohol and substance use may be particularly strong indicators of increased risk of suicide. Pay attention to that. Alcohol increases your risk. Substance use increases your risk. And I just told you 95% of those that are struggling with alcohol have had trauma. There is the correlation, right? So treating one without the other doesn't seem sufficient. Among those with alcohol use disorder, a greater severity of recent drinking is associated with a greater likelihood of an attempt and mortality. So those are very honest conversations. If they're struggling with alcohol and their depression and their suicidality, oftentimes they're like, I don't want to die. And you're like, well, then this might be a great time for us to really review your alcohol, because this is going to complicate that for you. It's going to make it a little harder. Individuals with comorbid alcohol use and a mood disorder have a greater risk of suicide attempts compared to individuals with just a mood disorder. So if you're an outpatient and you are working with somebody that is struggling with their mental health and they are struggling with your depression or bipolar, and they start to pick up alcohol, it's worth having a conversation about the risks that are increasing for them just by the mere act of alcohol being introduced. That's critically important. For those of you that work with teenagers, welcome to the world of a teenager, because guess what the two top subjects are, or two top substances are for teenagers who are currently running higher risks of mental health and substance use? Alcohol and marijuana. It's too early to know the data, but as we see more adolescents smoking marijuana and we see more adolescents, is that part of this? Right? So that, I don't know what the data is. I think it's still too preliminary for that data with the adolescents, but it's certainly worth paying attention to. That's worth that. So I go to a couple of questions. When client express suicidal, how often do you continue to ask them about it, daily, weekly? So that we will talk about. The data on marijuana use. So yes, there is in each of the slides, so you can show me, I'm highlighting where the data came from. So you are seeing directly tied to those, right? Because this is a pretty controversial topic. And so I want to make sure that people know that this is coming directly from data. So each of the slides, I actually put specifically where that data was driven from and where that data was connected from. So again, for that increase by 10 and the ejections, yes, it's on the slides. We will talk about it in assessments when we say how often should you ask them about it. Is there stats on why younger people are committing suicides due to bullying or feeling inadequate? Bullying is one of the risk factors. And so I know that they've identified it. Is there statistics that are directly linked to bullying? That I don't know of, but I do know that bullying has been one of the risk factors that has been flagged. What do we know about suicide running in the family? My partner was a fourth generation in her family to commit suicide, her mother or grandmother. So that's an interesting topic on multiple layers, right? So typically, and so I'm going to just do a very brief answer to the explanation. Is that we're looking at two factors. So if you have multi-generations of suicide, it means that you have multi-generations of substance use and or mental health and or substance use in the effect, right? So that is genetic, right? So we do know that those things are genetic. The second is that we are products of our environment and we learn behaviors that worked. So I'll leave it at that. What about impulsive suicidality related to dissociative events? We talked a little bit about the impulsivity, right? That's a direct tie to an individual that is more likely to act. And where can we find the stats on the weights we are discussing? So again, back to that, you will see it on each of the, anytime that I have statistics, particularly for this particular presentation, you will see the footnote at the bottom of each slide. All right, so the intersection. So just as an FYI, you can see at the bottom of that slide, it's small for you, but that is where those are where you can get it. So if you want the references, you can ask for that by request and we can send you the references, but I have purposely put those right on the slide. So you'll see at the bottom of those, the direct research that I'm pulling this data from. So partner violence, violence towards a romantic partner is an important predictor. Physical aggression towards a partner was associated with higher levels of suicidal ideation. I put this on here because I think that we see domestic violence. And again, at this point, I'm hoping that everybody understands how everything fully integrates. But this seems to be one that when we look at it, we tend to just put it in the bucket of trauma. And so when we look at partner violence, it becomes incredibly important for us to look at this in an integrated approach, because partner violence, whether it is the perpetrator or whether it is the victim, for a lack of a better word, it increases risks. So this is an important part for us because what it is also saying, and we're going to talk about that as far as risks and protective factors, right? Family connection, those are huge protective factors unless they are a risk factor. So if partner violence is happening, what we know for certain is that when there is domestic abuse and domestic violence, those individuals tend to live more isolative lives. Risk factor. Because there's so much shame to this that most don't admit it. And so again, if we are trying to say, you know, no shame in this game, which is a phrase that I use a lot, this becomes an important part of, are we asking about partner violence? Are we creating a space that doesn't feel like we're judging it, but we're really curious about it in the way that it's going to present for our patients? Partner violence is a very complicated situation, and behavioral health typically just says, stop seeing them. I'm not involving them because they're aggressive. I'm not involving them because they're violent, but are we isolating that person more? That's some of the stuff that we need to look at. Doesn't mean that we're trying to put somebody back in the hands of where there is violence, right? Which is a risk factor, but it means, do we need to connect them to other community partners? Do we need to look at ways to keep them connected? Do we need to provide them safety planning and conversations? But if we're uncomfortable with it, or we tell people what they have to do, that shuts them down, increases risk factor. Substance use as a risk, again, although consistent association exists between the two, as I mentioned earlier, the vast majority of those with substance use related issues will not die by suicide. So I don't want this to seem like every person that comes in with substance use is a suicide risk. It just means that it increases. You're seeing the data again, that 10 to 14 times greater, right? Emerging research that some individuals with particular types of substance use, which is what we highlighted, right? So these are just some of those takeaways, and the severity of their substance use may predict a greater likelihood of it. Right, so how often are they using? How long have they been using? How often have they tried to stop using? And what has it done to their financial means and their relationships? Those are all part of it. When we look at what places a person at risk in treatment, there's some things that we need to just understand from that experience. So what puts that person at risk in treatment? Because they tend to seek help when their life feels out of control. That would be a risk, right? When other life factors are also out of control. So as I'd mentioned, right, their relationships are becoming worsened, they feel more disconnected, they've lost their job, they are losing their house, right? So other life factors other than their just use is also out of control. Oftentimes individuals might seek help during the peak of their mood symptoms, right? When things are so critically bad that either they or somebody that loves them recognizes that they need to have care. And so I talk about this a lot within our own organization. Our patients are used to being able to learn skills in the crisis, but the real recovery starts with mitigating the crisis. So how do we provide them the skills to not go into crisis? Because most of our patients, when we ask them about their coping skills, they talk about their coping skills when they're in crisis. It's a lot harder to mitigate a crisis than it is to mitigate the crisis. So they're normally accessing help in the crisis. And the co-occurrence, right, of mental health and substance use. Here are treatment-specific risk factors. We're going to talk about this when we get into aftercare. And then we're going to tie into some of the assessment. Treatment-specific risk factors. Transitions. This will be critical when we start to talk about aftercare. So some of the treatment transitions put our patients at the highest risk. So what's a transition? A transition from an inpatient to nothing, right? If there is no continuum of care, if there is no collection of keeping that individual connected, supported, and accessing treatment, it poses an increased risk. So any new transition increases risks. A therapeutic discharge. So our against treatment advices, our administrative discharges because of behaviors that we are seeing within an individual, those put patients at risk. So again, for anybody that's on this call, that's ever worked with me, you hear me say these words all the time. I am always paying attention to our against treatment advice patients because those are our highest risk patients. Not only is this a transition, but their discharge means that they discharged in an acute crisis, right? You left against advice, meaning you were frantic, you were either agitated, you were having strong urges, something bad happened, it puts them at risk. So I am always paying attention to against advice. The history of suicidal ideations and attempts, the expectations of the worst if there is a relapse or a reoccurrence, and that is both for substance use and mental health. This, again, when we get to protective factors, becomes something that we start to explore in helping to prepare individuals, including families, communities, support. So when I say family, I mean whoever has the patient's back when they are leaving. That can be family of origin or that can be family of choice. So expectations of the worst. So are we prepared? What do we do? So if there is a reoccurrence, what happens? Here's what's most fearful and why a lot of individuals don't start sharing when they start to struggle, because they are afraid of being put into the highest level of care. So if I start to drink, I'm afraid you're going to throw me back into the ER or a detox. If I start to have suicidal thoughts or my mental health starts to worsen, I'm afraid you're going to put me back in a psych hospital. And so having very honest conversations of what it would take and what they can do to be able to be a partner in moving that, right? Giving them choice. That becomes a critical piece. And then the experience of acute life stressors. So again, if you've been in treatment, then there are acute life stressors. That is true. This is why I'm not a fan of telling patients and their families, right? Stress is a risk for suicide and substance use. Because stress is a part of life. So I would rather have them highlight some of the things that become risk factors so that we can add protective factors to it. But otherwise, we find patients and their families walking on eggshells because they're afraid that they're going to trigger the other person. But you can't live like that. And so if you're afraid to say it because you're afraid that it's going to trigger somebody, then that's where the secret sits. And then people do things behind the scenes as opposed to saying them out loud. Right? We want people to be able to say things out loud so that they don't have to say them inside their head to themselves and trying to navigate that. Because again, the more that they're doing that, the less their cortex, and they start to fall more into that system that starts to react. So the assessment. So we are going to talk about a few things when it comes to the assessment, both when we're looking at risk and protective factors, but also basic steps of risk assessment. I'm just looking at some of the questions. So there's a couple more questions. This is a hot topic. This is why I am thrilled that we are doing this today. Close to 600 of you coming on here today to learn more about this. So I'm so grateful that you are here, because the amount of questions that's coming through is a clear indication that we are all trying to figure out how to do this differently and to best support those that we are treating. So I am so grateful for your questions. I am so grateful that there's so many of you on here today. So when we look at the basic steps of risk assessment, here are some of the steps: engagement and therapeutic alliance. It's where it starts, right? So this is why it becomes critically important. This is the most crucial step in the risk assessment, because if this step isn't successfully negotiated, then the patient can't provide their honesty or their truth, right? So again, when you have a patient that openly says that they have a history of suicidality, that they're having these thoughts, think of what we do for them, right? And we'll talk a little bit about that when we talk about safety plans, right? You score very high on the CSSRS. We, as providers, engage in a lot of things to keep you safe. If you think about what exactly do we do, a lot of it is connection, right? We round on you more frequently. Somebody checks in on you, right? We make sure that there's no lethal means around you. We check to see if you're okay. We provide you additional support. But we need to be able to get to a place where it's okay to say those for those that aren't comfortable yet. Because again, while I don't have statistics for that, anecdotal, I will say a lot of individuals that we see that attempt tend to not be the ones that scored high. They were the ones that flew under the radar. So the engagement and the therapeutic alliance becomes critical in being able to say, am I comfortable with the words, I want to die? Am I comfortable with the words, I'm having thoughts of wanting to kill myself? Am I comfortable with having somebody say, I don't know if I want to be here anymore? If you are not, no shame in this game, but this is where I would encourage you to continue to seek supervision, your own counseling, because if we are not comfortable with it, they can't say it. Because we know trauma makes their brain incredibly acute to their surroundings, and they read people, right? I've worked with a lot of individuals that have had trauma, and they would call me out on stuff that I was like, man, how do you even know? Like, they knew when I had a bad day. Didn't even have anything to do with them. They're like, why do you look like you already had a bad day? I'm like, man, God, you're good. Because their brain, which makes sense to survival, their brain is so acutely aware of subtle changes in you that they see it. So you think I'm okay with somebody talking about suicide, but then when they say it and you start moving around in your seat, you change the subject, you're like, oh my gosh, like we got to do this thing. And your voice changes. They're like, oh God, I'm not saying that again. No, 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 no. They're going to put me in a psych hospital. Those are direct words. Those are quotes from patients. That another basic step of a risk assessment is that they have a psychiatric evaluation. A thorough psychiatric evaluation is critically important, right? Disorders commonly associated with the suicidal behavior, depression, suicide or schizophrenia, substance use. So having a psychiatric evaluation, making that okay as well, allows for partnership, integrative care, and allows for an extra set of eyes to be able to evaluate somebody who is quite literally an expert in the field of mental health. Identifying risk factors, which we are going to get to, identifying protective factors, which we are going to get to, because those two are so critically important, they get their own slides. Gathering information, so gathering collateral, asking the questions about ideation, plan, intent, and lethality. Think back of the person that I said that we were about to send to a higher level of care, not currently here, but in my past life, right? We were about to send somebody to a higher level of care who had no access for intent or lethality. That's exactly that's like a patient that's saying, I want to use today, but they're in your treatment space and they don't have access to alcohol or a substance. The only risk we have for that individual is them leaving. If that person left against advice, huge risk. But if they're still staying in treatment and we are able to provide them the support and the connection that they need within their community and their peers, then this is how they begin recovery. It's what it looks like. And then a collaborative history. I'm a huge fan of involving families. People know that about me. If you don't know that, you will. But family becomes a critical element to it. Because families have the collateral. Because you're talking to the person that's in crisis and they can't be alone in this. So families have to be involved, and family is whoever has your back. I don't care if it's family of origin or family of choice. You need to have some surrounding support, and we need a history of what's going on, because patients will be able to report to you what they can report, but you got other people that are like, that doesn't seem right. Every March, things get worse for them. Patient didn't even notice that. Collaborative history is critical to being able to start to recognize behaviors. I had somebody recently ask me, is this a pattern? I feel like the same thing happens time and time again. And I'm like, that's incredibly good insight. This is somebody that I've been working with for a while. But in the short term, we need somebody else that might be able to highlight where there's patterns, because sometimes when we're in it, we don't notice the patterns. We notice them. That's the whole recognize, right? That's the whole foundation of our curriculum. You got to recognize these things, because that's the way that we know when we have to regulate. Collaborative history is going to allow for that help. So when we start to assess some of the risk, here's some of the risks. So this is now, we are with a human being. We are looking at an individual. We'll get to some of the assessments, but in just our relationships, and I'm going to say something that feels a little controversial when it comes to talking to therapists. I always feel like I have to say, I am also a therapist, right? Proud of being one and have been one for many, many, many years. Sometimes we have to recognize what the most important thing for us to do in our job in that space. Because sometimes what we want to do is talk about things and the root of everything. But sometimes when somebody's acutely distressed, they don't need to get into the root. They need to be able to get into the recognize and regulate. And so we, as professionals, I always equate this to, like, if you went to a doctor and you had an open wound that could potentially end your life as a result of that open wound, and you went to the doctor and said, listen, I'm like struggling with my diabetes. Like, I'm like having a hard time eating. You know, my mom had diabetes, and these are all the things that I've really been struggling with. You would want that professional to say, Trish, I hear you. Like, you got some stuff you want to work on with your diabetes, but if we don't address this right in front of us, this is actually going to get in your way more. That compound fracture, that's actually what I have to address, because this could impact your life today. I'm not saying you shouldn't do the work that you need to work on down there, but that's not going to get you today. This is going to get you today. So when we're looking at assessing risks, this becomes important. And the reason why I say that is sometimes when we go into an individual session, we want to talk about all these things from the past, but what we probably should be focusing in on, their ideation and their intent versus a plan. We might need to talk about lethality. What's going on at home? So because your patients might leave against advice. So where you're like, well, they're here, right? So I don't have to worry about like a gun at home. They could leave tomorrow. They could leave tonight against a treatment advice. So in that session where you wanted to talk about somebody's feelings from years ago, which there is a valid time for that, right? I'm not saying that we don't ever get there, but we got to be able to make sure that we are triaging appropriately based on the level of care and the needs of the patient in the moment. If you've got a patient that's struggling with suicidality, that's more important to me than going back that way. And so I might be saying, so what's going on at home? Did you mention that there was a gun at home? And they're like, yeah, I got a gun at home. And I'm like, okay, so you know what we're going to do? We're going to call your family. Because what I hear you saying is that you want life. That's why you're here, right? I trust you. I say that word a lot. I trust you. So I trust that you want this. But in the event, we know that suicidality is impulsive. We know it's risky. We know that it can come out of nowhere. So why don't we put some safety measures in place so that we can ensure your safety? That's a priority. Well, I want to talk about the things that happened to me 15 years ago. I'm like, I'm sure you do. And there's going to be a time and a place for all of that, but we got to prioritize today. History of suicide attempts. It's important to know how they attempted, right? It's important to know what the response was. It's important to know if they tried to access help or if somebody stumbled onto them and found them. These are all important for us to know. What I don't ever want to hear anyone say is that this is just a person trying to get attention. Nobody should say those words. ever. Because nobody's inside of a mind. And even in the event that somebody was trying to get somebody's attention, isn't that worth noticing? Isn't that worth saying, like, hey, if this is the only way you get your voice heard, like, first of all, kudos to you for figuring out a way to get your voice heard. But like, we got to figure out some other ways to get your voice heard. I'm not shaming that game, right? We all want to get our voice heard and we all go into things. Some people yell, some people scream, some people. If this was the way that you got your voice heard, you don't have to be ashamed of that. That's not attention seeking. How dismissive and disrespectful. We're not going to say that. We're going to say this is how you got heard. But it's time for us to figure out some other ways that you can get heard. And by whom? That becomes a shift. Changes in your health, your psychology, or your disease status. So changes in treatment where you see the patient seems like he's physically or she's physically getting worse, right? Where there's a change in their mood, right? Patient that was presenting as really depressed and all of a sudden they were like, seems like he's doing fine now. You're like, how did that happen? Like, do we have a reason why we know? Like, are they taking their meds, right? Are they attending group? Because if there's no rhyme or reason to a shift in mood, then we should be paying attention to that. That's more important to me. So when you come into my session and you want to talk about 15 years ago, and I'm like, hey, over the last few days, I've noticed this change in you. Tell me a little bit more about that. What's going on with that change, whether it's good or bad? Tell me a little bit more about it, because that in the moment is more important than 15 years ago. Compound fracture, diabetes, prioritize. Recent losses, obviously, that would be one. I think we're pretty comfortable with that. Conflicted relationships. We're going to circle back around with that when we talk about family, right? And the lack thereof of engagement, oftentimes. Conflicted relationships. History of violence. Those are risks. So what I'm not going to do is isolate the patient even more so that I'm their only protective factor. My teams hear this all the time. If your patient thinks you're a coping skill, then they can't get well without you. So we are doing it backwards. Our job is not to help a patient to get well within us. Our job is to help a patient to get well without us. So if there is conflicted relationships and you but now the moment they have to live, they don't have the support that they need because the only support that they figured out was your treatment facility. We can't do that. We got to give them the skills and the tools and the connections so that they can sustain their recovery without us. And then reasons to live and motivation. Those are always fun questions. Honestly, I used to work with a lot of suicidal adolescents. And sometimes the way that I would ask about their reasons to live is I was like, what's your favorite football team? This is somebody that was actively depressed, having thoughts of suicidality, and literally would stop them in their tracks. What? I'm like, do you have a good, I don't watch baseball. I do watch baseball, but I don't care about baseball. And I would say, I only like football. Like, do you have a favorite football team? This is going to start helping me to see if there's a reason to live. It seems silly, but when they're like, actually I do. I love this, or I hate football, but I love soccer. You're starting to find little windows into this individual that becomes part of their motivation. It doesn't have to be the reason to live. I'm not going to get something philosophical. For some, I might, but it might be something as simple as like, I love watching, I love watching soccer. I go to my friend's house every Sunday. Sometimes it's that simple. But we ask these questions of like, what's your will to live? And if you've ever asked that question, particularly an adolescent and a young adult, but sometimes an adult, what's your will to live or your reason to live? They say, I don't even know what you're asking me. Welcome to the adolescents and the young adults. Or they say, I guess family, I guess this, right? And they tell you these things. And then you look at your treatment course and you didn't even involve them. They're like, my family, but they're really angry at me and I haven't really had a good relationship with them. But they just said that's the reason to live. And then you didn't involve them. And you're going to wait for them to discharge to start communicating with them. But they just told you it's conflicted. Risk factor, protective factor. So when we look at the individual risk and protective factors broken down, right, there's three categories that we can really look at. Personal risk factors and protective factors, relationship risk factors and protective factors, community risk factors and protective factors. So this is how we should be looking at them, right? So when I'm looking at a human, I am looking at all three of these. I'm paying attention to all three of these because these are how we assess risk for our patients in suicidality. And so any of the risks, which is what you see, I'm now looking to make sure that there's protective factors in those same buckets. If they got a whole lot of risks, we better make sure that they've got a whole lot of protective factors, because otherwise, what are their alternatives? So here are your risk factors. Substance use disorder, shocking, right? Some of these are pretty standard, right? And so you're looking at them, depressed mood, I've already talked about that. Discrimination. Experiences of racial discrimination can lead to psychological distress and increased suicidality. Do we ask that? Do we talk to them about that? Cultural identity issues and the role that that plays in their mental health is essential for providing culturally competent care. Do we pay attention to that? Do we pay attention to it in our organization to ensure that our patients feel safe? Conflict, isolation, or loss of relationships. Welcome to every family member. A support system assesses the availability of culturally relevant support systems. Family, community, organizations, right? So if there is conflict and isolation or a loss of a relationship, this is a significant risk factor. There is a researcher that does a lot of work on prevention. And what he talks about is these 3 C's: choice, collaboration, and connection, right? I'm going to talk about it in a minute, but think of those things. So you have those 3 buckets, right, that we're looking at as far as where risk factors and where we need to build protective factors. But I always like to think of them in the process of like choice, collaboration, connection. Those are the preventative: choice, collaboration, connection. So are we doing that? What you don't hear is processing of feelings. What you don't hear is some of these other things, because in risk factors for suicidality, and keep in mind, if you're working in an inpatient, every patient has a risk. Might be moderate, but every patient has a risk. If they don't tell you, it's because they're ashamed, right? But every patient has a risk for all of the reasons that we just talked about. So a history of trauma, 95% of them. Substance use disorder, welcome to the world. Depressed mood, most of our patients are co-occurring. Discrimination, you better ask. Cultural identity issues, you better ask. Relationship issues, there's nobody that has substance or mental illness that doesn't have conflict or isolation within their relationships. Job or financial loss, welcome to the consequences. Impulsive or aggressive behaviors. So these are interesting because when we see depressive symptoms, we tend to respond a little differently to them, right? And I talk about this a lot when I do my trauma training, because we tend to lean into them. Somebody that's withdrawing, somebody that's isolating, somebody that's sad, we tend to lean into that a little bit because we're like, what's going on? But when they're impulsive, we're like, man, they're so impulsive, like we almost give up on it. It's frustrating to us. Impulsive and aggressive, we're like, pfft. But that's trauma. We talked about the brain. And how when somebody sits in the limbic system, that's where impulsivity and the amygdala, which is the fight or flight system, which can present as aggressive. So those are risk factors for suicidality. Lack of access to healthcare. That's important, right? So again, the follow-up continuum of care, are you connecting them? So again, if we're doing a whole lot of therapy inside of a treatment facility, that's awesome. Is it? Maybe. Right. But if you're actually connecting them to their community, you're not connecting them to their own healthcare when they leave you, then we're putting them at risk again. And then the fear of stigma. How comfortable are we with the words, I want to die? How comfortable are we with the words, I want to kill myself? Risk factor is that they can't say those words out loud. So then what are the protective factors? I'm highlighting the connection piece. And I'm highlighting this because most treatment doesn't involve connection, except to the provider. I love if the provider feels connected to the patient and the patient feels connected to the provider. I don't if they're the only ones that they're connected to. Because if they're only connected to the provider, then they don't have any protective factors. So if we look at all these protective factors, Think of if you are not providing aftercare. Think if you are not involving the families. Think if you are not involving them in alumni. Think if you are not connecting them to their external provider. Think if you are not providing them PHP level of care if they're coming from an inpatient, or an IOP if they're coming from PHP. All of those in blue have a direct relationship to connection. Out of 10, they are 6 of the protective factors. That's how important it is. What you don't see is process. Not to say that there isn't. I'm a therapist as well, so I'm not saying it doesn't have a place, but I'm saying you better make sure that that place is where the patient is able to sustain this, as opposed to in the early treatment phases where there is acuity that needs to be addressed. Relationships, access to peers and support. So that can be alumni, that can be NA, that can be NAMI, that can be community events. Feeling connected to family, community, and peers. Those should be sessions. Those should be visitations. Those should be education, where the family understands the importance and the role that mental health and substance use plays on their loved ones, so that they have an understanding of compassion as opposed to anger and frustration because they don't understand the disease. Support. Children at home. Spirituality. How many involve that? How many even ask? I remember when I was a young therapist, I had to check the box too, right? I was like, are you spiritual? And they'd be like, I don't know, maybe, sure, yeah, I guess. And I'm like, well, do you go to church? And they're like, yeah. And so I would check the box, never to be asked again. And as I got further into my career and spent a lot more time looking at trauma and working with trauma, and it overlapped with a lot of substance use and suicidality, I realized, man, I had a person that was telling me one of their protective factors, and I wasn't even connecting the dots. I wasn't even saying, like, do you go? How often? Like, let me help. If they're in an inpatient, how do we keep you connected to your spirituality? Because it's one of your protective factors. This, for those of you working in substance use, these protective and risk factors, this is quite literally your BAM. This is the focus on the BAM. This is the reason why. So that is not a checkbox assessment tool. It is driving our risk and protective factors. Too often we're like, they said that they're feeling better. Their risk factors have gone down. They're not using drugs. And I'm like, when they go home, they have access to it. That doesn't count when they're in an inpatient, because we don't have access to substances in the inpatient. So you got to make sure that you actually have it. Motherhood. I'd rather talk about current motherhood than 15 years ago. Ability of physical and behavioral health care. I'd rather have a conversation about why it's so important for me to spend this session. I know you want to talk about some of these things. I hear you. And I also want you to talk about that. But what I know for certain is that we got to make sure that you're scheduled for your follow-up. Because if you don't go to your follow-up, that becomes a bigger issue for you. So I got to make sure that you got your primary care physician so that you can do the follow-up and you can get your medication. And I also need to make sure that we have transportation for you so that you can go to your PHP or your IOP, because those are actually bigger protective factors right now for you. Then when we look at some of the others, effective skills. So again, where we come in at Promises, we're providing skills every day, all day, skills. Moving away from processing and moving towards skills. Why? Because they're protective factors. Because you can't process yourself out when you die, but you can load yourself up with skills. You can recognize that you're being activated. You can get yourself regulated through some skills so that you have the choice to respond. Problem-solving skills. That's what we need. Those are 2 of the other protective factors. Coping skills, problem-solving skills. Yeah, that's what we want. Reduce access to lethal means, and then pets. Pets are delightful. We could almost throw that into another one of the blue ones because they are a connection. So I have had many a person say that they chose to stick around because they didn't know what was going to happen to their cat, their dog, their ferret. I think there was one person that had a ferret, right? And so I don't minimize that. I acknowledge that as a part of their commitment to something outside of themselves. And a recognition of, like, this isn't what you want, but this is what you're struggling with. Patient doesn't want to use substances, but that's what the solution is that they found. And for patients that struggle with suicidality, it's not what they want, it's a solution that they found. We're helping them to create new solutions. But you can't if you don't talk about it. Risk versus warning. So here are the warning signs. A little different than risk. So again, these are just looking at where I go, oh, patients change. These are warning signs for me. When I hear somebody that has no sense of purpose, I don't even know why I'm around here anymore. I don't know why I'm alive. Nobody loves me. When a patient says the words, I feel trapped. If the patient doesn't say the words, but they act the words, I can't go home to my family. I can't admit to the things that I've been struggling with. I have nowhere to go to. I don't have anything. Trapped. Increases the likelihood. That's a warning sign. That is more than a risk factor. That is a warning sign that they're going to do it. Feeling like a burden, these are warning signs. Leaving against advice and increased use are warning signs. Withdrawing from your group. So again, if you work in an inpatient or an outpatient and you run groups, look at not attending groups differently. Instead of looking at this punitively, like they don't care, they're not invested, look at it as a treatment opportunity to be like, I don't want them withdrawing. Right? This is a concern for me. And so that's how I approach it with people. I'm not angry you didn't come to group. I'm not trying to force you into group, but I'm like, this is a worry, right? You disconnecting, that's a huge piece to one of your protective factors. So like, what do we need to do to help you to get there? What do I need to do tomorrow to help you to get to group? Do you need a touch point? Do you need a fidget? Do you need some skills right before you go in so that you can breathe and regulate? Do you need an escape plan? So if you start to get really heightened or really agitated or you feel overwhelmed, that you have an escape plan that I can support. What do we need to do? I'm not angry at it, but I am paying attention to it. Dramatic mood changes. I don't care if it's a good one or a bad one. Pay attention. Hopelessness and then anger. I purposely wrote anger because most people think anger is a behavior that needs to be disciplined. And the reality is that for a lot of people, anger sits below that sense of, or actually it's above that sense of the deep iceberg of trauma, right? So at the tip of the iceberg, you see the anger. At the bottom of it, which is how deep this iceberg is, that's all of the pain. So something has triggered them and they learn that anger is the solution for them. So that's a risk for me. So I don't look at anger as frustrating. I look at it as a symptom. Here's just a quick kind of abbreviation from a different research project. I'm not going to go into it, but these are just, again, outlining pretty quickly. I liked how they did it. Screening and assessment. So I'm going to start going through some of these a little bit quicker because I'm not going to go into depth and because we have about 20 minutes. So this goes back to one of the questions earlier. All individuals should be screened at the intake. Psychiatric evaluation should follow up. Rescreening by clinicians. So the question was, how often? Repeat assessment should be done whenever there is a change in treatment settings, worsening of the patient's condition, or anytime you see the patient. So for us, every time a therapist sees the patients, we're going to rescreen. Right? You can do the shorter version versus the longer version so that you're not taxing a patient and annoying them, right? With a full Columbia, but that you should assess them. But if I see a change in the patient, yeah, I'm going to assess them. And if a patient says, why do you keep doing this? I say, because that's my job. In the same way, you go to a doctor, don't they check your blood pressure and take your weight every time you go? This is us. This is what we do. This is our version of your blood pressure and your weight for behavioral health. We assess you. We see if there's any changes because that's incredibly helpful information for us to figure out how do we respond to you differently. Some things might or might not work. And so I'm not doing it as a checkbox and being like, because we have to, because I got to do this assessment because we're told that we have to. And it's not a punishment of like, now you said that you're thinking of suicide, so now I got to do this assessment. It's because something changed. So in the same way, if all of a sudden you gained a ton of weight and you went to their doctor, they would start to investigate it. They'd weigh you and then they'd be like, huh, something's changed. Let's talk about that. So every time you should repeat it, every time you see that patient, particularly in an inpatient where it's a higher level of acuity for all the reasons we've already talked about today, but treatment settings, worsening of the condition, or if there's appearance of a new psychosocial stressor. I just lost my job. My wife is threatening to leave me. You know, somebody passed away, right? Anything that has changed a psychosocial stressor, then you should reevaluate it. I like to say that this is like your story. And so we're going to see these scores, But then as we start to navigate by providing you tools, as we start to get you connected to other folks, as we get you involved in alumni and we get you involved in treatment, I'm going to actually tie those things in to your scores so that you see you didn't magically get better. These are all the things that you're doing differently, and that's what helps your skills. That's it. I want them to know that. I don't want them thinking that they just happen to get better, and I definitely don't want them thinking I'm why they got better. I need them to see all the things that they did. All individuals should be rescreened at discharge. And then again, since the period immediately after discharge is one of the highest risks for suicide, early follow-up would be critically important, right? So that's why we want them to be involved in aftercare, because when you go to aftercare, they also reassess them. Keep them connected. These are the screening tools, right? So these are various screening tools that you can access and utilize. I'm not going to go over them because they're quite literally screening tools. All right, so prevention and intervention. So here we go. We're going to talk a little bit about MI. We're going to talk a little bit about some of the things that we can do. And so this was a great thing from the suicide prevention website. So 5 action steps for helping someone in emotional pain. Ask if they're thinking about killing themselves. Even as I say this, and this is why I keep saying it on this call, it makes people uncomfortable. Because they're like, are you saying those words? That word seems really aggressive. And I'm like, more aggressive than an attempt? I don't think so. I think that's actually what it is. Are you thinking of killing yourself? Because if I say, are you thinking of hurting yourself? That can be just self-harm. That's not what I'm asking. I mean, I can, if I'm worried about self-harm, I can say, are you thinking of self-harm? Like, have you been thinking of engaging in some self-harm? But that's a very different question. And that's what I feel like a lot of people sit on. They ask if you're thinking of self-harm. That is very different than are you thinking of killing yourself? Those are 2 different acts. Non-suicidal self-injurious behaviors, suicide. 2 different ones, right? Keeping them safe. So again, reducing the access to lethal items. Be there. There's connection. Help them to connect, quite literally connection. Stay connected. Keep them in a continuum. So somebody that does treatment and then says, I'm not doing anything, particularly if you are in an inpatient, they went from 24 hours of access of potential community connection to 0. That is not only a risk factor, their brain will literally go through withdrawal from the connection to other people. That's what happens. And we know the risks of withdrawal. When we look at suicide prevention strategies, this is based on 5 of the most common causes of inpatient suicide per the Joint Commission, right? These are some of the things that you can do within your facilities. Training your teams, environmental risk reduction, so looking at your risks within your environment to ensure that's the removal of lethal means. Screening and assessment, so making sure that you are doing the assessments, that you have an expectation of how often to do the assessments, right? And then you're following through with the assessments that are driving intervention. So it's not enough to just do an assessment and be like, okay, and the patient doesn't even know their scores. Screening and assessment is here you are, here's the intervention that we're going to do. These are some strategies, and then following up. Observation, so this is where we see the one-to-ones. This is where we have quicker rounds on an individual so that you can observe them to see if there's any changes in their presentation. And then communication. Communication to your teams, because the most important person to a patient in a crisis is the person standing in front of them. This goes back to training, but communication, watch the way that we're communicating this. How do we support a person? What I'm going to do, and I'm going to highlight this as part of our safety plan that we provide our patients, is to give everyone in the organization the tools on how to support a person, because if they don't know from the person's own words what works for them, then what we do is that our interventions became person specific. So I intervene the way that I like to intervene. Somebody else intervenes the way that they like to intervene. And maybe none of them are actually what works for the patient. So communication on what works for the patient so that everybody around the patient knows how to also successfully help to support that person. So here's where I was talking about choice, collaboration, and connection. So here's your interventions. Create solutions and troubleshoot solutions together. Collaborate on action plans and the use of skills. This is where you can tie in those assessments. Connection. Identify and strengthen reasons for living, which is your pets, your family, your friends, your community, your alumni, all of those things. right? Those are parts of the intervention. To providing it, I like to acknowledge a person, that I trust that what they want is recovery. And that when they start to feel overwhelmed, when they start to go into crisis, their brain is creating solutions for them that we're just trying to find new ones. No shame in that game. That's the hope. I'm not faking hope, right? Like, you'll be fine. This time it's going to be better. I'm saying, no, we got to figure out some of these things. I need you to recognize some of the bigger triggers, and then I need you just to regulate that. And then down the road, maybe you find out exactly why those are triggers, but maybe you don't. That's not what recovery is. You don't have to know everything to be able to recognize when it's happening. That's a shift. That's actually more hopeful than me just telling you, I hope it works out this time. Good luck. I'm like, nah, did you notice that every night at dinner, these are some of the risks for you? Like, that seems to be a really pivotal point. I don't know why yet, but this is where we want to load up some skills, because this is where you tend to have more suicidal thoughts. It's always in the evenings. Why is it in the evenings? I don't know. You don't have to know right this second, but you do know now that there's a pattern, and that's where we're going to start putting those skills. That's the integrative approach, because you're going to be working collaboratively with the entire team, including the psychiatrist. How to identify who is at risk. So certainly a CSRS, but as I said earlier, most of those that are going to be at risk don't necessarily present at risk. So track the behaviors, not the diagnosis. I've worked with first responders for years, and very, very seldom did they score high on the SSRS. Suicide prevention resources. So again, I always like to I have a coworker and a partner in crime that I work closely with that is what I would consider a Joint Commission guru. And so we always like to tie in why some of these things, because I don't like when people do things based on a checkbox. There are things that are ordered from the Joint Commission, from other auditing bodies that are not checkboxes, but because they are driving the appropriate clinical care to enhance our patients' success and recovery. And so when they talk about safety planning and interventions, which I'm going to talk about how we interpreted that, this is a brief treatment for suicidal patients in various settings. It is a collaborative effort in creating this treatment plan that drives warning signs, coping strategies, who are you connecting to, contacting family, AKA another connection, and connecting them to mental health resources, AKA another connection point. And so this is then what should be driving some of the intervention, so that each person knows exactly what they should be doing. This ties to the Joint Commission, not because the Joint Commission is trying to get you to be compliant, but because they are driving it, because this is what improves our patients, because they know where the risks are. That's not a checkbox. That is good clinical care. And so when we look at that safety plan, intervention, and approach, we want them to have the strategies to mitigate the crisis. That's what we want. And so we have created, where we are, this recovery skills plan. And again, it's a little bit small for you, but essentially this is, so it goes to our own curriculum, which highlights, again, recognize, regulate, and respond. And so it ties it, because I want the patients to start recognizing, what are your symptoms of wanting to hurt yourself? What are your symptoms of where your suicidal thoughts come in? Is it in the evenings? Is it after a phone call? Is it on the weekends? What are the physical symptoms? Is it in your stomach? Is it a headache? Is your back hurting you? What are your behavioral symptoms? Do you look angry? Do you look isolative? Do you look agitated? What are the behavioral symptoms? Because then we, as the support, housekeeping, family, community, alumni, therapists, CEO, we become the support, because then we notice them, not based on just what I've just gone over, but now this is personal. Now I know exactly what that particular person's physical symptoms are that they are starting to get triggered, behavioral symptoms that they are starting to get triggered, emotional symptoms. Because some people will say, I'm not going to commit suicide because I don't feel depressed. It's the rage that makes them commit suicide. So we have to be able to say, just tie all this together. Then regulate which specific skills help for you. So stop using, this is a soapbox again. I'm so over hearing the same 5 coping skills for every single human being in entire behavioral health. When you ask a patient, what are your top 5 coping skills? They all say the exact same thing. Exercise, doodling, coloring, journaling, breathing, and music is in there. How is that possible? How are the same 5 coping skills the same ones for every single human being? The reason why we are training people on skills instead of processing people's feelings is because they need to practice different ones. It might be a cold glass of water. It might be ice. It might be squats. It might be, they need to identify what their coping skills are because they practice them. Nobody fights an urge to commit suicide by taking a good old-fashioned breath, in the same way that nobody prevents using heroin from taking a good old-fashioned breath. That's not an appropriate coping skill. Breathe, I love it, right? It can help you to get regulated when you're calm, but not when you go into crisis. And so if this is created for all of our patients, there's no shame in this game because everybody has one. Imagine what it feels like if you are a behavioral health technician in the evenings, or you are a family member and they share this with you, and you know the exact skills that they've not only said that they work, they practice them, they know they work because they actually were able to feel better afterwards. And if you're in a treatment facility, you actually were able to then monitor it by assessing them. Use these skills, let me do another assessment on your depression or your anxiety. That's the game changer, right? And then how to respond. Who do I call? Connection. Who do I call if I'm having urges, which might be different than who do I call if I'm having strong emotions? Maybe you can't call your family. I worked with a lot of adolescents. They could not call their mom when they were having suicidal thoughts because mom was too triggered. But they could call mom when they were feeling sad. So that's different. Too often we say, who's your contact? And they're like, my family. You're going to call your family when you want to use substances? You're going to call your family when you want to commit suicide? They're like, no, because your family's going to react because they're also traumatized. So I love you being connected to them. I still want you to connect with them, but they might not be the phone call when you're having the urge to do it. You're teasing all of this out, right? And then your recovery capital, you're seeing this very clearly. All patients should understand the difference between recovery capital, risk factors, and protective factors. Because I don't have to negotiate anything when I look at a patient and they have 16 risk factors and 2 protective. I'm like, listen, you don't need to be a mathematician to figure this one out. You got 7 risk factors and 1 to 2 protective factors. This isn't a wing and a prayer. This isn't going to work. You got to load up on some more protective factors in order for you to be able to manage this. This is just how this works. That is the shift. So motivational enhancement. So when we talk about this, again, part of what we're going to talk about is motivational. This is choice. So how does motivational interviewing work in the space of substance use and suicidality that all correlates with trauma? Because motivational interviewing talks about choice. It talks about strengths. It trusts that the individual knows how to navigate themselves if they are just given the opportunity to understand how to do it. So it has some universal truths. All people want to be treated with dignity and respect. Fair. All people want to be asked rather than being told what to do about themselves. You're telling me what to do, but ask me, like, how is this working for you? All people want to be told why they are being asked to do something. So that's just, again, going back to dignity and respect. If I'm saying, like, listen, you can't drink alcohol when you're feeling really depressed, they don't know why. When I say, can I help you to understand why I'm telling you alcohol would not be a great idea right now? Can I help you to understand? I'm not saying don't ever smoke weed again. Welcome to the world of having these conversations. I'm saying, can I help you to understand why if you do this while you are actively struggling with your mental health, it could make things worse? That's their why. People need to understand their why. People like given options, that's choice. And everybody wants a second chance. Because if they're accessing you, then they want to be here, period. So that is always my starting point. If you're seeing me, then you wanted to be here. Well, I'm only here because somebody made me. And I'm like, well, then that person was important enough to you that here you are. So that's still you wanting this. So I trust that, right? So when we go over, I'm not going to go over this quote, but it is a good quote. If you're looking at the integration of it, finding out which stage, right? So the stages of change, I like looking at stages of change as more than just substance use. I like looking at stages of change that, listen, you could be in a action stage of change for your mental health and taking your medications, but you're in the contemplative stage of going to the gym, right? So, and you're in the pre-contemplation for alcohol. Like, so then you can actually see, like, these are your strengths. This is what you're doing really, really well. And we utilize some of those same skills to be able to help you with some of these other areas that you want to move, because they all relate, right? They can articulate the pros and the cons better than I can. Here's the thing, for suicidality, there's a lot of individuals that the crow of having depression exists. I work with a lot of individuals that are afraid of losing their depression. That's okay to say. Nothing crazy about that. It's comfortable, feels like a warm blanket. And so we're not trying to get rid of who you are. We're trying to make sure that you don't get to a place where you end up making a decision that you don't want. That's all. We're not trying to change you, because sometimes it's through that darkness that they find their beauty. So I'm not trying to get somebody that struggles with depression to say, like, I'm not supposed to have this anymore, because there's people that they feel comfortable in it. That's okay. Those are words you can say out loud, but it sounds crazy to them. And so you'll hear them say that. Why would I say that? Why would I feel comfortable? Because you know it. There's nothing wrong with that, because there's some benefits. That's the pros and the cons. So what do you gain from it? We don't have to change that. We're just trying to help you have some space where you can respond in ways that don't make things happen that you don't want. That's breaking the silence, right? And so again, the priorities of MI is choice and collaboration, period. So I'm quickly going to go over these last, and then there's a couple questions I'm going to try and squeeze in the last 3 minutes. But additional evidence-based treatment. So in addition to MI, you got DBT, which is dialectical behavioral therapy, right? Which provides skills, regulation skills, distress tolerance skills, mindfulness skills, emotion regulation skills. This is a research-backed, particularly as it pertains to suicidality, because it tracks it, because it measures it, because it tracks it, because it goes after specific behaviors. They are teaching individuals the skills that they need to be able to navigate their recovery. CBT and CBT in suicide prevention. So that's the CBT SP, right? So these are different ways. So you're going after the thoughts. Again, CBT is another research-based methodology. And so it is going after the thoughts, which you can see on that model, right, of suicide, where it can decrease problem solving, which is what happens when you're having suicidal thoughts. And we're trying to empower them to challenge those thoughts so that they can change the way that they think, engage in some of the skills, changing the behaviors, which will then ultimately change the way that they engage. Not processing. So neither of these have you seen where they do a ton of processing of their feelings. They're both sitting in the idea of moving them towards skills that they can learn to be able to challenge behaviors in ways that allow for them to continue to move through their recovery. Follow-up needs. This is the importance of aftercare. So strengthening economic supports, protective factors in their environment, and healthy connections. I cannot say this enough. If you have not connected your individuals to the outside world, then they are going to cycle. Because if we are the only ones that are allowing an individual to feel safe, then we are the only ones that they are going to feel safe with. So if we don't involve the environment, then they are not going to learn how to find their recovery in the environment to which they're supposed to live. So that is going to be the critical piece of involving families and the importance of that aftercare. The risk of suicide after psychiatric hospitalizations is one of the highest. So overdoses is also one of the highest. So critically important to have conversations. This is a far more important conversation to me than talking about 15 years ago and what's happened to you. Helping them to understand the importance of your aftercare is critically important in helping somebody to sustain their long-term recovery and improving their outcomes. So with that, this is the last slide for your crisis. I'm going to turn this over to Callie for the last slide. So again, I appreciate all of you being here. I am grateful that this was attended so well so that there are more and more individuals that can communicate and speak about suicide and trauma. And so thank you for joining us today. And now I will turn it to Cal.
Thanks. Yeah, thank you guys so much for being here. A lot of great feedback. If Trish did not get to your question, we will probably add in some notes into our follow-up email where you're going to get the recording, slides, and additional resources. So the conversation will have to end here. You can view all of our recordings online on YouTube. So I'll send out that link as well if you didn't already get it. And then hopefully we'll get to see you all back in May and June. Again, you'll get an eval from me later today. It's coming through Jot form, and fill that out before next week. I think that's everything. Thanks, Trish. Great job.
Thank you, everyone. Appreciate it. There are a couple other questions I can, as Callie had said, I can answer those and we can kind of put them in just in a little bit of a Q&A for the emails that she sends out.
I think that's great.
Appreciate it. Have a good one, everybody.